Hi guys, welcome back again. It's Dr. Saru. It's another Good Friday. And we're going to be talking about polycystic ovarian syndrome. The coming video will be polycystic ovarian syndrome versus polycystic ovarian disease. What are the differences? And even in line of management and such things. Today's video is sponsored by an upcoming artist. I'll post some of his work here so that you can be able to see. I'll post his Twitter handle and Instagram handle. You can check him out whenever possible. So guys, definition: it's a syndrome of ovarian dysfunction along with the cardinal features of hyperandrogenism and the polycystic morphology, ovarian polycystic morphology. It is the most common endocrine disorder in women. Accounts for about 80% of women in their reproductive age. And it's one of the major causes of anovulatory subfertility. When somebody has polycystic ovarian disease or syndrome, most of the time there's anovulation. To note, it's associated with increased risk of type 2 diabetes and cardiovascular events. So I'm sorry, I'd mentioned 80%, but it affects around 5 to 10% of women in reproductive age. That 80% it's the 80% cause of anovulatory subfertility. Sorry for that. Etiology is unknown. However, there's been linked in genetics and insulin resistance and hyperandrogenism that has been postulated to be causing the polycystic ovarian syndrome. I'll just go in depth just a little bit to explain. Normally what happens is there's tonically elevated LH. That in turn leads to increased androgen production from the thicker cells and stroma, therefore decreasing the SHBG, which in turn there's increased unbound estrogen and androgens. So increases, again, that causes increase in pituitary sensitivity to GnRH, which increases, and in turn there is increase in LH production and decrease in FSH due to inhibin. So in that state there is hyperandrogenism, which in turn produces amenorrhea by its anti-estrogenic action. I will add on to that slide so that maybe you understand when I'm doing the comparison between polycystic ovarian disease and polycystic ovarian syndrome. But I hope if you listen well to me and you try to write it down on your own, you can actually get the gist of what I'm talking about. So clinical features: there is oligomenorrhea, that is 65 to 75%. Facial hairs, that name normally gives me a problem in pronunciation, so I'm not going to do that. So there's excess facial hair growth to about 30 to 70% of most cases. And subfertility, which is caused by the ovulatory subfertility, about 75%. The other features that you might find, the patient might be obese. There may be history of recurrent abortions or miscarriages, and acanthosis nigricans. So there's a criteria for diagnosis, Rotterdam criteria. It requires that at least out of the 3 variables, 2 to be present in the patient that you are dealing with. One is regular or absence of ovulation, or absent ovulation cycles. And then the second one is clinical or biochemical features of hyperandrogenism. So if your patient has those 2 already, that automatically it qualifies them to, it qualifies you to say that they have polycystic ovarian disease. And the third feature, or the third part of the criteria, is polycystic ovarian morphology on ultrasound. So if you get a volume of about, is it 10 cubic, 10 mils, larger than 10 mils, that automatically qualifies as polycystic, multiple cysts in the ovary, that is polycystic ovarian syndrome. So for diagnosis, you have both, after you've clearly examined your patient well and you found the features of hyperandrogenism and other things that are clearly indicating that this patient could be having a polycystic ovarian syndrome. There are laboratory tests and ultrasound criteria for diagnosis too. So for the laboratory test, of course, you're going to do a whole array of a hormonal profile, and you find that the patient would have elevated testosterone levels. There is a decrease in the sex hormone binding globulin, and elevated LH and LH to FS ratio is increased. And sometimes you might find increased fasting insulin levels. On ultrasound, you're definitely going to find the polycystic ovarian morphology there when you do the ultrasound. So for treatment, as I had mentioned before, some of the clinical features include obesity or an obese patient. There is lifestyle modification clearly that needs to go in hand with the medical, or even if you decide to go to surgical management of polycystic ovarian syndrome. So for the lifestyle modification, weight loss, you encourage the patient to lose weight, start on a healthy diet. I think I'll do another video maybe when I'm doing the differences between Pcos and Pcod. I'll do a video, or rather I'll add on the foods that have been researched on that also help with maintaining a good amount of weight. Being healthy weight-wise, and also helping you with treatment of polycystic ovarian syndrome. And then 2, these combined oral contraceptives. It helps with the correction of hyperandrogenemia, and also helps with regulating your menses, so that at least you can start to have ovulation. It will be easier for somebody to track when ovulation is supposed to happen, when your menses have been corrected. And that is mainly for people who are not thinking of conceiving at that particular moment. There's also cyclical progesterone that has been shown to give good results for some patients. For ovulation induction, clomiphene has been widely used for that, to help with the same, that is to help with your ovulation, plus the insulin resistance that would have started. Metformin is also normally prescribed at 500 milligrams BD. I was telling you about the surgical treatment. There is some that have been documented, like laparoscopic ovarian drill, and laser vaporizer. Don't forget to subscribe, like, comment, and if you like this channel, don't forget to leave a thumbs up Until next time on Friday, see you. It's Dr. Saru. Love and love.